Hello, Insta family. It is Dr. T here, calling in at about 5:15 WA time on this wonderful Wednesday. We are at Hump Day, and I'm here for a rapid fire Q&A. Yes, I am still at work today. Big day today, but a fantastic day, and I'm loving it. I'm loving it when you get 5 pregnancies out of 7 possible pregnancy results today. That's a pretty good odds. So we're celebrating here at Pivot, celebrating all of our pregnancies that we had today. So I'm here for you guys for the next 10 to 15 minutes. If anyone has any rapid fire Q&A questions, please drop them into the chat down below. Remember the rules. Try and make your question as generic and as short as possible. I will be giving as generic an answer as I can, and no question is unreasonable. I can guarantee you that whatever question you're asking, there is definitely somebody else out there who is keen to ask the same question. So while you guys are all hopefully jumping on, Life of Brit, Kathy, Kobe, Mum in the Making, good to see you guys back, Guzzy Lou, Michelle Arnold, I hope you're going really well. Drop your questions. Oh, there's your, I'm still celebrating here. Almost 26 weeks. Yay! Congratulations. Over halfway, my friend. This is a fantastic result. Hope you are feeling really good. Mum in the Making. Does anything different need to be done in FET using donor embryos? That's a really great question. So obviously a donor embryo is made up of the genetic material of an egg donor and or a sperm donor, or it is made up of the genetic material of a couple that have previously created embryos for infertility and perhaps have decided altruistically to donate any embryos that they don't wish to use, which I think is an amazing thing for anyone to do is donate egg, sperm or embryos. So do you need to, so I suppose the question is, are those embryos any different to you creating embryos yourself? And I suppose the simple answer to that is no. We don't have any different protocols for somebody who might be a donor recipient than if they were having the transfer of an embryo that they made from their own genetic material. So we still have natural cycles, or we have modified natural, bit of low dose stimulation perhaps with Gonal F or Puregon or one of those medications, or we have a fully HRT FET, so where we give you the estrogen and the progesterone. And there isn't really any differentiation based on whether the embryo that you're receiving is made up of donated material. So I guess the simple answer is no. So the preparation is the same, making sure that you're taking folic acid, making sure that you're looking after yourself, making sure that you're living an average life, sort of not over-exercising, not under-exercising, not drinking alcohol, not smoking, having a wide variety of fruits and vegetables, Mediterranean-style diet, watching your weight. All those things that we would be advising you to be doing, you do, whether it's a donated embryo or it's your own genetic material. So hopefully that is a helpful answer to you. There is another question here from Greta Mack. For someone not having a period cycling, would you recommend myo-inositol progesterone 14 days on and off? Good question, Greta. I guess it really depends on why you're not cycling. So if you have polycystic ovarian syndrome and as a result of that, you have what we call anovulatory cycles, so you're not ovulating every month, therefore you're probably not having a period every month, it might be every couple of months, then managing the polycystic ovarian syndrome is the way to go. And first line management of PCOS is always lifestyle, particularly if there is overweight or obesity involved. The purpose of myo-inositol is as an insulin sensitizing agent, much like metformin. We would give that in the context of someone who's deemed to be insulin resistant to lower their insulin, And by lowering the insulin, you lower their IGF-1, and that lowers the drive to androgens, which feeds back. So if you've got lower insulin, lower androgens, you have an increased chance of spontaneous ovulation. So if you had PCOS, then it would be reasonable to include myo-inositol. If you are growing a lining, like with polycystic ovarian syndrome, you do produce an estrogen, then taking progesterone for 14 days, matures the lining, therefore allowing you to shed it after you have completed your 14 days of progesterone. If you weren't cycling because perhaps you had a functional suppression of the pituitary, perhaps you're over-exercising or you have a low body fat percentage, and your pituitary is turned off from stimulating your ovaries, then you're not really going to have much of a lining to mature and then shed. So cycling progesterone is really not going to be that helpful. So I do think that it's important to determine what is the reason why you might not be having a cycle, managing that, and then considering whether those two treatment options would be appropriate for you. So hopefully that's helpful. Mrs. English Lady, I haven't seen you in a little while. What does a frozen embryo transfer involve if you want to have another baby using a frozen embryo? Great question. Really great question. Again, it comes back to whether you are having a normal menstrual cycle or not. Of course, the first thing I always inquire is whether you're breastfeeding or not, because breastfeeding can interrupt cycles. So if you're back to normal cycles and you want to have a frozen embryo transfer, it would be very reasonable to do it in a natural cycle. Of course, all those things that you need to do to prepare for conception, like taking folic acid, all the things that I've just talked about, would be important to put in place. I always like to, if it's been a couple of years, perform a pelvic ultrasound to ensure there's nothing like a polyp or a fibroid that might interrupt the ability to conceive. And then do baseline bloods again to look at the endocrinology, make sure thyroid function and prolactin and all those sorts of things are normal before I proceed with an embryo transfer. And then the sort of technique would be, do I use a natural cycle, a bit of low dose stimulation, modified natural cycle, or even an HRT, FET? So that's really what we do to prepare for a frozen embryo transfer. Hopefully that's helpful. Professor Vollenhoven is on. Lovely to have you. Natasha Yolanda, I have had 2 scans 6 to 8 months apart, and the reports are contradictory. It states possible polycystic right ovary, however, previous scan reported left. Can it shift? Can it shift? Well, I guess it firstly depends on where you're getting your scans. I would always recommend that you have a tertiary level ultrasound performed. So one performed by a women's imaging centre who understands how to measure the antral follicles, because antral follicles are a certain size. They are between 2 and 9 millimetres in size. So you've got to be careful that it's not a general scanning place that might be measuring the really small follicles and including them in your follicle count. So I would always recommend a tertiary ultrasound. Polycystic ovarian syndrome is exactly that. It is a syndrome, which means it's a cluster of features. One of those features being evidence of polycystic ovarian morphology, and that can include one or both ovaries. And it doesn't necessarily have to be the same ovary if it's just one ovary that they're looking at, because what they're looking at is dimensions, size of the ovary, and they're also looking at the antral follicle count. And you're absolutely right, that can vary over time. So 6 to 8 months, surprisingly, is not such a short time, but it is it's a diagnostic criteria. It's not a pathology necessarily. Another question from Natasha Yolanda, and how do I get a definitive answer as to whether I have PCOS? Good question, Natasha. So there is a wonderful website called the Jean Hales Foundation. Hales is spelled Hailes, which has some fantastic information for lay people about PCOS and will also help you see the diagnostic criteria. So what you need to do is you need to go to a women's health GP who understands the diagnosis of PCOS. You utilise your pelvic ultrasound, you get some blood tests done, and they ask you a lot of questions about your cycle, and they will determine whether or not you fit the criteria of PCOS. If you're not happy with that, then find a second opinion, absolutely. Oh, yes, Mrs. English, sorry, with PCOS, no natural periods. So, no natural periods, again, you could look to do ovulation induction, so induce ovulation if you've got PCOS for an FET, or often the easiest way is to just simply give you the estrogen and give you the progesterone, and that's called an HRT FET. And so that's commonly what we do for someone who doesn't have an easily stimulated cycle. The Fertility Village would love to hear your thoughts on LIT. Spell that out for me. What does LIT? After 8 failed transfers, 1 miscarriage and a biochemical pregnancy. Just define for me what LIT is, please, and I can help you out on what my thoughts are. I'm guessing you are referring to a therapy for recurrent implantation failure, which is certainly defined as the transfer of, well, there's a couple of different definitions, but the one most commonly used is the no pregnancy after the transfer of 3 good quality embryos, and how we define good quality embryos is somewhat vague. But if you can define what you mean by LIT, oh, LMIT, DQ alpha gene. Oh, okay. What are my thoughts on it? I think very little about it, to be frank, because it's not mainstream practice. And the problem with, or the challenge we have with recurrent miscarriage and recurrent implantation failure is that when you start to look at higher order numbers of implantation failure, so more than 3, more than 6, more than a dozen transfers, really high numbers of embryos transferred, and we have transferred chromosomally normal embryos, so that's been proven, because that's probably our most robust test, is proving normalcy of an embryo. You start to look at fewer and fewer studies with good numbers in them, because it's kind of like a pyramid. You are examining less and less people, because there's less and less people who have had 12 embryo transfers and no success, for example. And when you get to that point where there's fewer people to examine in a study, you start to lose the ability to discriminate if a therapy works or it doesn't work, because there's no good quality large studies, and most of them are not randomized. So something like DQ alpha gene testing has not undergone robust investigation. So as someone who practices evidence-based medicine, I'm then practicing something that has not been proven to be an appropriate marker for for incompatibility, if you like, nor has the treatment of it been proven to actually work. And so I would absolutely be making sure that everything else has been assessed first, the things that we know about. The anatomical abnormalities such as the polyps and fibroids, the endocrine issues, the quality of the embryo, the transfer techniques, the endocrine environment. They would be all of the things that I would be examining before I would be considering the out-of-the-box thinking. And there are other out-of-the-box thinking that probably has even more robust information than DQ alpha gene screening as well. Things like uterine natural killer cells. I mean, we've been talking about that for years. And it's still not clear as to whether UNK cells are even involved or the treatment of them actually improves outcomes. So that's where my thoughts are at when it comes to those things. Yeah. And yes, the whole idea of putting a patient's blood under the skin, I mean, there's a lot of risk associated with that from an infectious diseases point of view as well. So yeah, I don't think much about it because it's not an area that I commonly practice in. Hopefully that's helpful. Whew, guys, you've stretched me today. These have been some really good questions, quite diverse questions. I think we might leave it there unless there's anything final that has jumped into the chat. Nothing has. Thank you so much for joining me. Just a quick update. I am at session number 12 out of 19 radiation sessions. Still doing really well, still feeling quite good, still at work. Apparently next week I get my booster sessions, and it's after that I can expect a little bit of a downhill run, but we're just going to suck it and see. We're just going to ride this roller coaster, hold on for dear life, and check in with you guys on a regular basis. So I will look forward to seeing you next week. See you soon.